and we'll put this up on Facebook and YouTube afterwards. So without further ado, I will start the presentation. So yeah, I just really wanted to talk about this. This is certainly a question that we talk about at the bedside quite a bit with nurses, with RTs, and with the medical residents and surgical residents. It seems like we use an undue amount of Lasix, and sometimes it doesn't always make sense. So I want to just review the thought process and especially why it might be important in COVID. This slide I also want to bring up because this is hopefully something that we'll discuss over the near future. As more information has come out about COVID with the pandemic and with some of the anxieties around feeling like there's nothing we can do and we're seeing so much death and disability, there's been a rush towards trying to find new, exciting, novel ways of treating what effectively is still ARDS and severe hypoxic lung disease. And I put this up to sort of remind people that what we really know that saves lives and likely improves outcomes is pretty simple. We've tried all the things that we're doing now in other situations for ARDS, and none of them have ever worked, aside from these three. So I think in addition to being innovative and looking for new possibilities, it's important to double down on doing what we know works really, really well. And those three things would be lung protective ventilation, so ARDSNet, restrictive fluid strategy, which is what I'm going to talk about today, and then Santa in prone positioning, which we kind of heard a little bit about from Dr. Slezer a few weeks ago. But I do think it's important to highlight that these are the only three things in addition to minimized sedation, daily SBTs, and treatment and prophylaxis of delirium that improve outcomes in ARDS. So I think it's really important that we talk about this as well. So the first question before we get to Lasix is, why do we give fluids? We give probably the most common medication we give in the ICU is intravenous fluids. And the question comes up, why? Well, really everything we do in the ICU relates to trying to improve perfusion. Perfusion is the delivery of nutrients and whether or not that equals or satisfies the metabolic demands of the tissue. Perfusion is related to the mean arterial blood pressure and oxygen content, and I'll explain how fluids fit into this as we go. MAP is cardiac output and systemic vascular resistance. Cardiac output is comprised of heart rate and stroke volume, and stroke volume is composed of preload, which is really volume status, afterload, and contractility. The reason I put this up here is because it's important to realize that the only purpose that giving volume serves, the only physiologic outcome it can benefit, is if it improves the stroke volume and if that improves the perfusion. Any volume outside of that, if we give it for a reason that doesn't lead to an increase in stroke volume, has no positive impact and only negative impact. The vascular resistance is influenced by the radius, and the oxygen content, which is not part of this talk, but I just want to use it as a moment to slam dunk on PaO2. Oxygen content is dictated by the hemoglobin, the SAT, and the PaO2, but changes in the PaO2 are multiplied by a factor of 0.003, whereas saturation changes are by a factor of 1.34. So we don't really care about the PaO2 in terms of perfusion. So I mentioned this, that fluids serve the only purpose to improve stroke volume, to improve perfusion. And this is a graph which is showing on the x-axis the preload or the volume status, and on the y-axis the stroke volume. And you can see here in the purple at the top the effect of volume on a normal ventricle. So the idea is if you're starting from a lower stroke volume, you give preload and it improves and increases. And this happens continuously up until a certain point. And you can see a fluid bolus on the right side of this screen in the purple ventricle has very little impact on the stroke volume. And so would not probably benefit the patient tremendously compared to at the far end of the other end of the spectrum. You can also see that in a decreased ventricular function, so in a patient with a cardiomyopathy, a septic cardiomyopathy, a pre-existing LV dysfunction, giving fluids has a very diminishing return. You start to flatten this curve out more quickly, and the improvement in stroke volume is a lot less. So just keep this in mind. This is why we give fluids. Why do we have to give fluids, especially in our patients with ARDS and septic shock? Well, one reason, which is pictured here, is we get vasodilation. So in SIRS, when we think about sepsis being the most common, but burns, post-op, and it causes inflammation, it releases inflammatory cytokines and we get vasodilatation. So this is going to drop our blood pressure, and this causes hypotension and hypoperfusion. Now, this is certainly one etiology that has no benefit from having more volume. You're increasing the size of the tank, and so you could either decrease the size of the tank or fill it up with more volume. This is a picture which doesn't show exactly what I'm talking about, but it has the heart connected to the arterial system and then through the capillaries back to the caval system. So we talked about vasodilatation on the arterial side, but the big change that we see in sepsis and distributive shock processes from inflammation would be the venous capacitance system increases. So if you look at the blue side there, which goes back to the IVC, the venous capacitance can increase dramatically and acts as really a reservoir for fluid we give during the treatment of distributive shock processes. So what you'll see oftentimes is, again, we're increasing the size of the tank on the right. We give volume that satisfies the size of that tank. It goes through the arterial system. We might see an improvement in our perfusion metrics, like urine output for a few minutes to an hour. And then it basically goes and just sits in the vena cava. It doesn't actually go back and recirculate because the capacitance is so increased. And the ramifications of this are really, if you think about the capillaries as a pressure gradient, where you have to have high on the arterial side and low on the venous side, increasing caval pressures by increased capacitance, all it does is serve to increase the back pressure, so you have less perfusion. And the last reason we have to often use fluids and the physiologic construct that generates hypotension, there's no good picture for this, but I found this to be a very disturbing picture when you search sepsis, so I put it in. You have LV dysfunction. You have LV dysfunction that happens as a result of sepsis, as well as RV dysfunction. So some of the cytokines will cause a relaxation or a dilation of the ventricles, which increases their filling pressures. And this is sort of hypothesized to be one of the reasons why you need to have increased fluid, because you have higher filling pressures. So these are the physiologic reasons why we give fluids, and the overall reason is to improve perfusion. And then the question is, how much fluids? So in order to decide how much fluids, there are as many metrics available as you can think of. One paper that's interesting that answers this more recently is from 2016 in JAMA, and it's really applicable to our patients. It's, will this hemodynamically unstable patient respond to a bolus of intravenous fluids? Which is really the whole point of this talk, and we're getting into Lasix. So what they looked at was a number of static measures, things like CVP, urine output, physical exam findings, and found that really they had very poor sensitivity and specificity. So their ability to predict whether someone would benefit from fluids was in the range of 50%. So if somebody, for example, had a CVP that was above 8 or 9, the likelihood they respond to fluids was about a coin toss, so not useful. What they did find were useful were three things. Firstly, the most useful thing is something called a passive leg raise test, which is pictured here, where a patient is inclined at 45 degrees, and then the legs are raised. The legs and the venous system in the legs contains about 500 cc's of fluid. So the thinking is that if you have an improvement in your cardiac output, and in these trials, they looked at Swan-Ganz catheter measurements, but something in terms of your cardiac output improving by 11%, then the patient was likely to respond to fluids. Now, all of these things, and this specifically, should not be conflated with the fact that they need fluids, but it's the sense that if you give them, they may respond, or they're more likely than not to have an improvement in their cardiac output. The second thing that they looked at was pulse pressure variation, which is pictured here. So in the top graph, you have their ventilator airway pressure graph, pressure against time. You can see expiration and inspiration. And then on the bottom, they have their pulse pressure variation. I think when a lot of us look at the art line tracing, we think that if there's a big swing, so from the end of inspiration down to the systolic pressure, between that and the end of expiration, if there's a big swing there, that may indicate volume responsiveness, which is probably potentially true, but pulse pressure variation is actually the difference between diastolic and systolic in expiration versus inspiration. And a difference of 10% here is felt to be, again, possibly indicative of response to fluid. And the last thing is POCUS. So I think asking for a volume assessment from POCUS has become almost comically ubiquitous in our units. It's worthwhile understanding what this does and doesn't tell us. So here is a picture on the top left of the liver with the heart on the right, where it says right atrium, and then the inferior vena cava in the middle, the black tube. It's sort of stylized with color on the right. So if there is a lot of variability between inspiration and expiration, between the diameter of the IVC, and in this study, they would look at a change of 15%. Again, that may indicate a responsiveness to fluids. The number of caveats to this, though, are too many to list, but I guess I'll say that this is only valid in patients who are spontaneously breathing, probably relatively calm and cooperative, and who are not receiving any invasive breath. So patients who are receiving NIV or invasive mechanical ventilation, who have a mix of spontaneous effort and controlled effort, this is not useful. What is more useful is superior vena cava variability on TEE, but that's not really readily available at the bedside. So suffice it to say, with all the caveats, if there's a variability in the IVC diameter of more than 15%, again, this suggests that patients may be able to respond to fluids. So this is how we decide if patients need fluids. Why are fluids bad, and why do we move towards Lasix in this talk? Well, first off, they're acidotic. So we don't often talk about this, but normal saline has a pH in the 5s, and Ringer's lactate is slightly less acidotic, but the pH is still 6.6, 6.5. So if you're giving liters and liters of that, it's no wonder that patients do become progressively more acidotic. What is the effect of the acidosis? Well, at the renal level, and we're giving fluids usually for low urine output, it causes renal artery vasoconstriction, so the glomerular filtration rate decreases, and we get water and salt retention. So we've shown that in post-op cardiac surgery, post-op kidney transplant, that Ringer's lactate, because it's less acidotic, probably has better outcomes than normal saline. However, just suffice it to say that giving fluids leads to an impairment in renal function. And you also get the increase in that back pressure I mentioned. So when your venous capacitance is high, it causes back pressure on the kidneys. From a cardiorespiratory point of view, if you think about that curve of preload to stroke volume, once you've got to the maximum amount of benefit and the curve flattens out, then the fluid doesn't go forward, and stroke volume, it just goes backwards or sits in the lung. So you get pulmonary edema, and you also increase the strain on the LV. And then not insignificantly, you have edema that builds up. So it's almost a standard paradigm. Patients come in, they get a lot of fluid, and they spend a week trying to diurese it off. Their legs are swollen, they don't mobilize as well, they get DVTs. And I think that this is just accepted as the paradigm of critical care medicine. But for reasons that I explained, if we're treating predominantly a vasodilated condition with fluids to try and fill the tank rather than constrict the vessels, this is probably not necessary. And Rob Arnfield always brings up the fact that if you think about 1 liter of fluid, we just give a liter bolus, that's 3 pounds of weight that the patient has to work off and pee off. And so this is a not trivial amount. So what I want to show you here is sort of how we can conceptualize this and why it's difficult. So this is time on the x-axis and urine output on the y-axis. And imagine this is your typical patient with sepsis or ARDS. So in ARDS, about 68% of patients get an acute kidney injury. In sepsis, it's between 30 and 40%. So the majority of patients start off on the left side of this curve with a decent urine output. It's going to dip down below 30 as they develop that sort of septic ATN picture. And this is when we start to usually give fluid. But we don't actually know whether or not the patient just has this temporary process that's causing septic ATN where they're going to rebound and they're going to be able to start making urine within 24 to 48 hours, or if they're going to end up requiring dialysis. And the reason we give fluids is really to prevent this red line because we don't know if the patient's on the green line. But what I would proffer is that it probably doesn't make much of a difference. And I'll show you some of the explanation for why it might, whether or not they're a responder or not responder, I think it doesn't make a difference, but also we can make it worse by giving fluids. And the obvious ramification to too much fluids here, as I mentioned, pulmonary edema and our sort of protein disease, and in COVID specifically, we get ARDS. What's important about ARDS is it's inflammatory pulmonary edema and it's non-cardiogenic. So sometimes if you're wondering why patients aren't hypertensive, they're not swollen, and they're on Lasix infusions, any extra water that they have in their body because of the dysregulated function of their lungs will go into their lungs. And if their lungs are the biggest problem, that's what's limiting their recovery. then that's the reason why we want to make sure they have very dry lungs. So that's enough about fluids. Now I'll get into what Lasix is. So this is, I think, reflective of what some people notice in the ICU, that with basically if anything happens, if a patient coughs, if a patient moves, then we usually respond with Lasix. And so I'll just describe what Lasix does and how it works. This is a diagram showing some of the functions of transporters of the kidney. At the top, you can see the glomerulus, where blood comes in from Bowman's capsule. So the blood vessels feed the renal system, come in here at filtration. Blood goes around, it goes to the proximal tubule. Sodium will leave spontaneously according to a concentration gradient, and similarly with water through the loop of Henle. But if you look right in the middle of the screen where it says loop diuretics, we see a co-transporter. So we have sodium and potassium as well as chloride leaving through a transporter. And what Lasix does is it goes into the tubules and prevents the function of that transporter. So we have more sodium in the tubule, water follows sodium. So as sodium goes through the tubule and gets excreted, we have more water that's excreted and the patient loses volume. That's how Lasix works. What's also kind of important and interesting, I guess, for a separate type of topic, but if we keep sodium in the tubule, if you keep following around to the distal convoluted tubule, or DCT, you can see here that there's another sodium chloride receptor where thiazides work. So this would be like hydrochlorothiazide or metolazone. So the idea of combining those two is you use Lasix to keep it in the system here, and then you use metolazone to make sure that the sodium stays in. So you just sort of optimize the diuretic effect. So that's how Lasix works. Let's talk about whether or not it has evidence, or what the sort of thought process is here. So why do we use so much Lasix? This is number one. So this was the FACT trial. It was, you can see, fluid management strategies in acute lung injury, which was a PF ratio less than 300, and now we would call ARDS. And what they looked at was two different management strategies: a conservative fluid strategy, where they strove for CVPs less than 9, and a liberal fluid strategy, where they tried to have CVP less than 13. And what they showed here was a number of different things, but I'll point at the sort of primary outcome. This is the time on the x-axis, and then the proportion of patients on the y-axis. And what they found was, in terms of the top things, there was no difference in survival. So if you had the liberal strategy or the conservative strategy, your survival was similar. But what was different was the second lines on the bottom. So breathing without assistance in the liberal strategy there were less patients in that bottom hashed line than breathing without assistance in the conservative group. So what this FACT trial showed, it was done in 1,000 patients, and I mentioned the CVP targets. No difference in mortality. In terms of the 7-day fluid balance, they found that it was negative 100 mils in the conservative group over 7 days and positive 7 liters in the liberal group. My internet's getting crummy again, 1 second. So what they found as well, a few things. So the conservative group had better oxygenation indexes. They had more ventilator-free days. They had lower plateau pressures. They had lower PEEP requirement. They had less ICU days, and they had more days of positive neurologic function. So overall, this showed that a more conservative, lower CVP strategy, so less volume, seemed to improve all outcomes. They also found that there was no change in acute kidney injury. Now, what you could argue from looking at this is that the patients who did well and were more negative were just more healthy. So this study was reanalyzed in the American Society of Nephrology, the journal for that. And they looked at this a few years afterwards. And what they noticed was that of the 306 patients who developed an AKI in the FACT trial by day 2, that the higher dose, so this shows you on the top, the cumulative fluid balance. You can see that there was a separation in the black circles, which was the restrictive fluid group, and in the gray hashed area is the liberal group. So there was definitely a difference in fluid over the days, and also the dose of Lasix that was used was significantly different. But what they found was that higher Lasix doses were negatively associated with mortality. So what that means is that patients who had higher doses of Lasix had better survival than patients who received less Lasix. They found that when they adjusted for 19 potential confounding impacts, positive fluid balance was associated with an improved 60-day mortality. However, it's still sort of, this is post hoc, this is not the point of the trial. And so it draws into question of whether patients who achieve negative fluid balance on their own do better, or if we help them, if they actually do better. So this was sort of prompted a group out of Toronto. Many of these providers are ones that are in the Canadian group. So John Marshall's the chief investigator, and he's a big guy in sepsis. They did the RADAR trial. This was a retrospective cohort study looking at 10 ICUs in Canada and the United States. It looked at 400 patients and just looked at their fluid balance and tried to make some conclusions. So the first interesting thing I found was in terms of the different components that fluid that patients get, and then their overall fluid balance contribution. So if you look at someone's overall fluid balance, 35%, which is the largest component, is just medications. Now, this is probably more surprising to the physicians because we just think if we order 12 antibiotics that they go in concentrated syringes and make no difference. But almost 40% nearly of the fluid a patient gets is just meds. Maintenance accounts for 27%, and then the resuscitation fluids, which would be boluses, so anything that's not a continuous infusion, was only 24%. So what this shows us, I think, is that the sort of maintenance creep or the amount of fluid that we give just by maintenance can dramatically increase the patient's overall fluid balance. And what they found here was basically you can predict based on the way this talk's going that negative fluid balance was better. So in the top bars here with the solid squares, this is the cumulative fluid balance for non-survivors. And you can see as time went on, non-survivors had more and more positive fluid balance up to day 7. And then in the middle with the open boxes, we can see the cumulative fluid balance for survivors. So they clearly are different, they clearly separate. What they found was that your survival was improved if you had either spontaneous or iatrogenic, so medication-induced negative fluid balance by day 3. So that was their big finding. And interestingly, in this study, it was retrospective, it was small. They found no change in acute kidney injury. So the patients that received Lasix had no change in their AKI rates. So the other question I just wanted to touch on was how much diuretic or how much Lasix we should give. We talk about infusions, we give boluses, we give at different frequencies. So this trial was done in 2011, published in New England. It was called the DOSE trial, and they enrolled 308 patients who had acute pulmonary edema. So slightly different than our COVID or ARDS patients, but still important. And they had a 2-way randomization to infusion of Lasix or bolus, and then either high or low dose. What they found here was firstly looking at their acute kidney injury outcomes. So you have the changing creatinine on the y-axis. On the x-axis, it compares bolus to continuous infusion. And you can see that the creatinine increased by a little bit more, so 0.07 compared to 0.05, but this was not statistically significant. And these are American values. And then the high dose Lasix compared to the low dose was also not statistically different. And what they found here in this chart is the diagram comparing continuous versus bolus, and the outcome on the y-axis is composite endpoint of death, rehospitalization, or emerge visits. So here they found there was no difference between continuous and bolus. What's interesting though in this study was that the bolus group had on average 100 milligrams per day of Lasix, which is a fairly large amount and probably higher than, especially by day 3, if we're trying to target negative fluid balance, higher than many of us would have for Lasix. So what I would take out of this is that there's no impairment, there's no worsening from a continuous infusion of Lasix versus bolusing. Anecdotally, I think many of us find that it's easier to account for the fluctuations in medications and swings in volume that are given with a continuous infusion. And it certainly doesn't appear to have any safety harm or profile in terms of acute kidney injury. So I'll finish up by just talking about some of the practical points in terms of Lasix and the reasons why we're often prompted to think about stopping. So one of them is hypernatremia. And I think this is important. Hypernatremia is associated with profound amounts of the sensation of thirst, which patients often complain is the most disabling symptom they remember during the ICU. And I think that we can predict patients on high dose diuretics are going to develop hypernatremia and thirst, and we can institute treatment with free water. Now, if it seems counterintuitive to do the two of these, oral or enteral ingestion of free water, it doesn't equilibrate as equally as the fluid losses and the free water losses you get with Lasix. So while we do want to decrease the overall volume of the patient, we get into trouble when we outpace the free water redistribution. So patients should not develop severe hypernatremia. And I would actually say that this is an opportunity for a nurse-driven protocol, because we talk about this every day. It's the same thing where the sodium goes up, we end up using free water. If they have enteral access, the sodium goes up higher, we increase it by a bit. And this is not something that I think is something that can get missed and we could probably do better at. We often hear that the patient is needing to have their potassium magnesium replaced quite often, so maybe we should stop the Lasix because of that. Sometimes often the patients develop a metabolic alkalosis. And I left out here urea, but they will often develop high levels of bicarb and high ureas. And the question I think becomes appropriately, well, what does it matter if the patient's not alkalotic or if they have a high bicarb? What would that impact in terms of their weaning if they're still volume overloaded? Probably the biggest concern that we hear about is that we're overdoing it. So the patient's too negative, they're 2 or 3 liters negative in a shift. And I guess the framing I would use for that is that we can manage the other things above in terms of the metabolic derangements. We can manage blood pressure changes, which are often not related to volume. But we have no problem giving 10 liters of fluid or having a patient who's very sick get 10 liters positive fluid balance in 24 hours because we'd all say, well, they needed it. Well, I think we can look at it the same way. If the patient has massive amounts of edema and is on high levels of oxygen, they need it. They need to be as negative as possible. So I think if it's working, if we're getting a great diuresis and they're getting better, that's not really a reason to stop it. The other two just practical considerations that I think are very less important, but Lasix does have a sulfa moiety, so if patients have a true anaphylactic allergy, we should be aware of that. And that given in large boluses over very quick time periods, concentrated, Lasix can induce hearing loss, but that's not generally how we run it. So I kind of mentioned that this is how I would suggest mitigating these concerns, that we give free water for patients who are developing hypernatremia. We replace their electrolytes, ignore their bicarb. I think the overdoing it is great. We should continue to do that. The sulfa allergy is something to be aware of, but doesn't seem to impact the majority of patients, and the hearing changes are not significant. So to close off, I'll just give you some of my hot takes on how I think we should change our management of volume and Lasix in the ICU. I think we need to reframe the question of, do they need volume because they're tachycardic, because they're hypertensive, because they have a decreased urine output, and reframe that really in terms of, will more volume be harmful? We know that more volume increases their days of ventilation, it increases their their incidence of acute kidney injury. So we should switch this around to say, are they going to be harmed by getting more fluid, or do they really need it? I think we should get rid of maintenance IVs. I think that this is something useful in a patient who's NPO waiting for surgery, who's completely stable, and we want to avoid acute kidney injury, but we have a massive contribution of maintenance to overall fluid balance, which we know is harmful in the ICU, and we just don't need maintenance fluid. I think that we should give boluses of fluid, and that's based on evidence of hypoperfusion. So their lactate's rising, they look like they're in shock, so they're not perfusing properly, and they have one of these 3 metrics, which I would proffer pulse pressure variation or passive leg raise are the 2 that we should be basing our decisions on, and ultrasonography in certain situations. I think that if we give fluids in a bolus form and they don't respond, we should just give them vasopressors. If they have a vasodilatory condition, then the solution for that is changing the radius of their blood vessels. It's not to fill the tank up with volume. I personally think we should stop measuring cumulative fluid balance because it doesn't take into account their insensible losses, which are usually massive in patients who are febrile and breathing with a minute ventilation of 15 liters per minute. So I think it's unhelpful and it's inaccurate. And I think you can look at the patient's physical examination and their overall condition to tell whether or not they're volume overloaded. It's usually not subtle. And then I also think we should remove the gastric contribution. So feeds and free water and oral meds, they don't really get redistributed in the same way that IV fluids do. They don't have the same dramatic acute impact on the vascular system, and they have different levels of absorption. So I think we should just get rid of that from our ins and outs. So that's it. I think that in conclusions, that avoiding a positive fluid balance is one of the 3 strategies, maybe 4 or 5, that will likely to actually benefit patients with SARS-CoV-2. Hopefully we get some new exciting drug that comes out and saves the day, but I wouldn't hold our breath. And I think we should really double down on things we know how to do well. Negative fluid balance appears to confer a survival benefit, and it does confer lung and renal benefits, and that we can anticipate and manage the complications of diuretics. So that's all that I had for the presentation. Let me just come back in here. Does anybody have questions? We only have 22 people, so I'll just maybe stop the recording and see if anybody has questions. You can call in, type in, text.